Hi everyone, it's Emily Bach. I'll be presenting my week 13 case study on cystitis. The patient is a 26-year-old G0 coming in with lower abdominal pressure and urinary frequency. She's been to the office 4 times the past year with dysuria and has been treated for UTI. She's sexually active and on oral contraception. She has a negative GYN history. She feels her UTI symptoms are occurring within 12 hours of sex. Past medical history of PCOS. Medications include Lowestrin, multivitamin, and omega-3. Allergies to ciprofloxacin, and vital signs are below. Important subjective data to ask includes the patient's past medical history, including prior cystitis, pyelonephritis, kidney stones, or other urinary symptoms, as well as her current medications. Her sexual history, including any new partners, history of STIs, if she's experiencing any vaginal discharge, vaginal pruritus, or any other symptoms of an STI, when her symptoms started, if she's having any symptoms of dysuria, sensation of bladder fullness, suprapubic tenderness, flank pain, and/or bloody urine, any changes in urination, including frequency, urgency, urinating only small amounts, nocturia, and/or any leakage of urine, and if she's having any systemic symptoms like fever, chills, nausea, vomiting, all those things. Data. So the physical exam should include a general appearance of the patient, her vital signs, if she's experiencing costovertebral angle tenderness, an abdominal exam should be conducted, and depending on her history, if we're going to be ruling out urethritis or vaginitis, she may need a pelvic exam. Diagnostic tests. She should have a urine dipstick and urinalysis done today. A urine dipstick that is positive for leukocytes or nitrates is likely a UTI. My diagnosis of this patient is recurrent acute cystitis. Recurrent cystitis is 2 or more UTIs in 6 months or 3 or more UTIs in 1 year. Women presenting with classic signs of acute cystitis, a bladder infection like dysuria, frequency, urgency, and/or suprapubic pain without any vaginal symptoms like discharge or pruritus, can be considered to have a clinical diagnosis of acute cystitis. My plan for the patient, so diagnostic tests should include a urine culture and sensitivity. This is the standard of care for patients with recurrent UTIs. It helps identify what bacteria is causing the infection, and which antibiotic is most appropriate. In terms of pharmacological and non-pharmacological treatment, the antibiotic I would prescribe to the patient is 100 milligrams of PO macrobid twice a day for a total of 5 days, as well as over-the-counter pyridium, which would be 200 milligrams orally 3 times a day for 2 days, which would help relieve her burning with urination. This patient needs extensive education, including lifestyle modifications, so she should be educated to wipe front to back, taking showers instead of baths, using a gentle, non-toxic liquid soap, for example, a baby soap, urinating after sex, urinating frequently, increasing her oral intake to anywhere from 2 to 3 liters a day, using tampons when she has her period instead of using pads, avoiding birth control methods like spermicides and diaphragms. If she continues to have these UTIs despite lifestyle modifications, then she may be a candidate for prophylactic antibiotics to help prevent UTIs. Women who are at an increased risk for UTIs compared to men because of the shortness of the urethra and their anatomy, proximity of the vagina to so the proximity of the urethra to the vagina and the anus just makes it easier for bacteria to enter. The patient may need a referral to a urologist if she's had recurrent UTIs since the age 16 or earlier, more than 1 episode of acute pyelonephritis, possible kidney stones, or an infection caused by Proteus, and ongoing hematuria or relapsing infections are all indications for a urology referral. Follow-up typically acute simple UTIs don't really need to be followed up. Her symptoms should resolve between 24 and 48 hours after starting antibiotics. If her symptoms persist after 48 to 72 hours after starting the antibiotics, then she should come in for an evaluation. Here are my references. Thank you for watching my presentation.